So thank you everyone for coming today. Today we've got Stephanie O'Neill, who's going to take us through some on-call cardiology emergencies from the perspective of an F1. Thank you, Steph. I'll leave it up to you.
Cool. Hi, yeah, so I'm Steph. I'm one of the F1s currently at Wythenshawe. And today I'm just going to be going through some F1 on-call kind of cardiology sort of themed emergencies. And these are all the things that I've seen during my on-calls in the past couple of months. So hopefully very relevant, especially, sort of working up to sort of being an F1. Cool. So the format today, so we're going to be going through 3 cases. And they are, fairly common on-call scenarios. So things that, will probably crop up during your time as an F1. And it's sort of more about knowing some initial investigations, initial management plans, knowing when to ask for help, really. So sort of going through sort of, familiarizing yourself with some of the scenarios, and then sort of hopefully reassuring you that, most of these are fairly sort of straightforward and common, and sort of generally reassuring you that it's okay to ask for help, really. So probably sort of going into F1, this is probably how you feel, and it's certainly how I felt and sort of, still feel now, really. But hopefully after today, it might reassure you a little bit, go through some sort of common, investigations, management plans, and yeah. So the first case, so this is a case that didn't happen to me, but happened to one of my friends a few weeks ago. So she was the F1 on call for surgery overnight, and a job comes up on iBleep saying that patient is complaining of chest pain. So in that sort of scenario, what would you do initially? I don't know if anyone wants to sort of shout out sort of initial things that they might do, or sort of initial sort of management plans, things to think about. I don't know if anyone wants to volunteer, sort of be brave.
Can you just confirm what iBleep means for everyone?
Okay, so iBleep is a sort of online system that lots of hospitals use for on-call scenarios overnight, especially. So nurses can put jobs on iBleep, and things get sort of stratified by how urgent they are. So things can go on like, do you bloods or do you cannulas, and that might be a green job. Patients who are unwell, so go on a sort of an amber job, and certain things come up as a red job. So that means you need to go and review them urgently. So patients with chest pain goes as a red job, people scoring sort of 7 and above. So it's sort of a system, instead of the nurses sort of just bleeping you, it's a system of having it all online, that you can sort of just work through it systematically. So it gets put on iBleep basically, and that's a common sort of system that lots of hospitals use basically.
Sarah said she'd like to do an ATE and take a comprehensive history from the patient.
Yeah, definitely. So in this scenario, let's say you're sort of on another ward, you're with a sick patient. In this scenario, you will have so many calls overnight of people complaining of chest pain, and most of them will be absolutely fine. So it might be, I had one the other night that was patient with chest pain, and had a cardiac arrest a few days ago, had CPR, and was complaining of some sort of chest wall pain. So, you've got different scenarios and sort of different levels of sort of concern, really. One thing you can do is sort of quickly phone the ward. And that's what you should probably do for sort of most jobs, really. So phone the ward and get a bit of a background. So you could phone them and say, are they stable? Are they, what's their blood pressure? Things like that. What's their background? So what they come into hospital with? What's their past medical history? So do they have any sort of cardiology background? And most importantly, can you do an ECG? So that will save you so much time sort of getting the nurses to do an ECG before you get there. Otherwise you'll arrive, they'll say, oh, we don't have a machine, and it'll just sort of add to the, the time pressure, really. So yeah, but yeah, you're absolutely right. So you should go and see the patient, have a read of the notes, and go and do a full A2E. What the nurses tell you on the phone is that it's a 76-year-old man. He came in 5 days ago for degenerative small bowel obstruction, and he had a DGLisis, so was taken to theatre 4 days ago. And in his background, he's got high blood pressure, he's had previous cancer, he's got type 2 diabetes and CKD, and his medications you can see as well on the right. And the nurses say that, yeah, he's been absolutely fine up until today. So the ward round said, he looked well, he was pain-free. The plan was to, do some bloods, get his NG tube out. And his admission ECG is documented as normal. And current obs, so, his heart rate, so he's a bit tachycardic, his blood pressure's up a little bit. So he's probably got, he's definitely got some chest pain, given, his blood pressure's up, he's a bit tachycardic, his rest rate is up as well. So the things sort of going through your mind at that point are, what could be causing it? So, from my point of view, you're sort of thinking, he's post-op, has he got PE, or is this sort of cardiac in origin? So you go and see the patient, and I advise really that as you walk into a ward, if somebody, if the nurses are concerned about somebody, before you go and sit down and read the notes, just go and eyeball them. So just go and see how urgent it is that you need to go and review them. And immediately you see that he looks pretty unwell. So he's grey, he's clammy, he's sweaty, and he tells you that he had sudden onset chest pain about 20 minutes ago. It's going into his arm and into his jaw, and he's got some increased shortness of breath. So, there's sort of no point to sort of guessing that this is probably cardiac in nature, and probably some kind of ACS really. And that was certainly the thing that would be going through my mind at this point. So the nurse has done you an ECG. I don't know if anyone wants to be brave and sort of talk through the ECG if they're sort of feeling up to it. Yeah, I don't know if anyone wants to have a go.
I don't mind doing it.
Yeah, go for it.
So, I mean, first of all, obviously, you want to know it's the right patient's ECG, the right identifiable. Can't see that here, obviously, but we'd check that in practice. Then, the first thing I normally do is look at the rhythm strip. So there isn't a rhythm strip here.
Yeah.
And I'd calculate the rate and rhythm. Hard to do that here, obviously, without it being there. Then I'd want to see if it's regular, if it's tachycardic, bradycardic, and then I would want to look at the P wave to see if it's sinus rhythm. From this, it looks regular, but like I say, it's hard to tell without a rhythm strip, and hard to assess the rate as well.
So Graham, what you can do is look at for the rate. You can just look at our intervals, and there's a formula, sort of 300 divided by the number of squares. So for example, if you look at V3, you can quite nicely see the first beat. There's an S wave. Can you see that?
Yeah.
That just happens to fall on the line, and you can see there's 1, 2, 3, 4 big squares.
Yeah.
Before the next one. So if you do 300 divided by 4, you get 75 beats per minute.
Great.
So you can kind of do that and eyeball that. And then the other thing with the rhythm, you can assess the rhythm even without a rhythm strip. So if you look at so you're looking for P waves, and the best leads, you can look at lead 2, is quite clear, and V6 is quite clear as well, V4.
Grant, so it's probably regular. It's around 75 beats per minute, and it's sinus rhythm. Then looking at the PR interval, it's a little bit hard to see, but it looks normal. 1, 2, 3, 4 little boxes. The QRS complexes they're not wide. The ST segment, I don't see any. Maybe some ST segment elevation in lead 1. There's 1 millimeter, but it's not in adjacent limb leads. AVR, there is some ST elevation and AVL. So that, and then in the chest.
What do you think about V2, V3, V4? What do you think?
Yeah, and then in the chest leads, it's there's ST elevation in definitely V2, V3, 4. So that'd be an anterior STEMI. And then I check for any reciprocal changes, like T wave, ST, T wave inversion, or ST depression. There's maybe inversion in lead 3.
Yeah.
And what's normal in AVR, so it's not inverted.
Yeah, exactly. So as you said, so you'd be concerned about patient definitely having a STEMI. An anterior sort of STEMI would be your concern, really.
Yeah.
So just to go back on that, Steph, do you mind just very quickly? So actually, there is, the anterior ST elevation, but also look at the T waves. Can you see those T waves? These are very hyperacute T waves.
Yeah.
And just look at that and just memorize that, because that is usually the first sign of a STEMI, is that you get these type of peaked kind of hyperacute T waves, which is actually, you get that even before ST elevation. The other thing is lead 1 and lead AVL. They are lateral leads, and there is ST elevation in those leads. 1 millimeter, remember, is significant in the limb leads. 2 millimeters in the chest leads. And in terms of reciprocal changes, if you look at lead 3, there is some ST depression in lead 3, but not in, and maybe a little bit in lead 2 as well, but not AVF. So there is some inferior reciprocal changes. So yeah, carry on.
Definitely. So, I mean, at this point, your working diagnosis is going to be ACS and a STEMI. And again, I'm sure you guys have done this to death, to be honest with you, but it's just sort of a quick reminder. So the things that sort of fit in the history, I mean, he's got sudden onset chest pain, he's nauseous, you know, he's got a bit of a temperature, he's feeling short of breath, and obviously some ST elevation, you know, or sort of seeing a new left bundle branch block on an ECG would make you concerned. And I'm sure if you did his TROP now and then sort of compared it in 3 hours' time, I'm sure you're going to see a pretty significant increase. And in terms of your management plan, so this is sort of fairly straightforward, and I'm sure you guys know the general systematic approach for sort of managing ACS. In terms of sort of what to do when you're an F1 on your own, at this point, so do an A to E. So make sure the patient is stable. So, you know, listen to their lungs, you know, listen to their heart sounds, get their blood pressure, you know, check they're not sort of decompensating in any way, and then get some help. So I think at this point, there's no harm in trying to sort of, you know, getting help early. So you'd want to speak to, depending on where you're working, either the med reg or the cardiology reg. So they're the person that's going to need to come and, you know, sort of sort this out for you. And also speak to your senior. So if you're the surgical F1, your sort of surgical team need to know about it. So either your SHA or your general surgical reg. And that's for a few reasons. So they need to know what's going on in their own patient and come and see them. But also, if you remember, this patient had an operation 4 days ago. So, you know, I'm sure at this point, they're not going to turn around and say, don't give them antiplatelets. You know, this is the sort of situation where, you know, the patient's having an acute MI, they're going to say, give antiplatelets. But you want to just run these things by people before you do it, and then start loading them. So the general protocol with Ensure anyway is if a patient's going for PCI, so 300 milligrams of aspirin, which is fairly sort of standard for both STEMI and sort of NSTEMI, unstable angina, and then also then sort of loading them with ticagrelor, so that's 180 milligrams. Then get them sort of, you know, their pain under control, so giving them some morphine. So 2.5 milligrams is what you can start with. You know, if they're vomiting, then give them some anti-sickness medication, and then you need to arrange them to go for a primary PCI. So if you're in a hospital that has got that on site, then that's great. And if not, you need to sort of start arranging them transfer to another centre. And I think the main message of this one really is that time is critical. So don't be sort of faffing around and don't be worrying about calling for senior help. So if you're concerned that your patient's having a STEMI, get help early. So call the cardiology registrar. And even if you're not 100% sure. So I had a patient last week who I wasn't 100% sure if it was ST elevation or just sort of an abnormal ECG. Just run it past somebody. There's no harm. Nobody's going to shout at you for just sort of being, you know, staying on the safe side of things. And I say that's sort of quite a quick case just to sort of show you that, you know, these things do happen, and you probably will encounter people having STEMIs on you and things like that. And get help early is the main message of that one.
Steph, do you mind just going back a slide? Sorry, one more back.
Yeah.
So basically, generally speaking, if you diagnose a STEMI, okay, there is a primary PCI pathway, and that usually involves phoning your tertiary centre. And with Ensure, there's a special number that you call. If you're not sure about the ECG, then yeah, get either a medical reg or the cardiology reg to have a look at the ECG. In these situations, if someone's having chest pain, you see them for the first time, I would generally give them GTN. So try sublingual GTN, maybe 2 puffs of GTN if their blood pressure is okay, and then reassess, because sometimes they can have, it could be angina or unstable angina rather than a STEMI. And in that situation, what you'll find is that the pain resolves and the ECG normalizes. That's slightly different to a STEMI in that situation. So I would probably not rush in with the morphine straight away, give GTN spray, but if they're still in pain and they've got ST elevation, then they may need morphine. And then with the antiplatelets, for a STEMI, we tend to say you can give the aspirin 300 milligrams, but then wait for us to review regarding whether, you know, the ticagrelor, and usually we'll make that decision if we're going to take the patient on or not. And in this particular case, be careful, because you need to know what their hemoglobin is.
Mm-hmm.
You need to make sure there's no active bleeding. You want to know what their platelet count is, what their clotting is. So there's a number of factors, and they've had recent surgery. So I've had a similar case like this a few months back. It's almost identical, really. And we had to speak. I spoke with the general surgeons about the risks of and you know, antiplatelets and the risks of and so on. And they actually did agree to go ahead with it. But sometimes if it's day 0, they may say, well, it's a very high bleeding risk.
Mm-hmm.
But yeah, thanks for that case.
No, not at all. So the second case is a case that happened to me a few weeks ago when I was on surgery. So it was a Sunday night, and I was on sort of ward cover for surgery. And I walked into the surgical ward, and the nurses came and grabbed me and said, there's a new chap who's come up from A&E, and he's just developed some chest pain. So sort of asking a bit more history. So he was an 86-year-old man, admitted that same day under general surgery. And he'd come in with some reports from his wife of him having fresh red PR bleeding. And prior, you know, up until that point today, he'd been sort of fairly stable. And then about 20 minutes before I saw him, he had sort of a large volume, fresh red PR bleed. And then shortly after, he developed some chest pain. So on admission, his bloods, were, fairly static rate. So his HB was sort of a bit low, so 97. Otherwise, not too bad. So white cells were normal, urea not too high, creatinine fairly normal as well. And his background, so he's had a previous STEMI and a previous CABG as well. He has got some memory impairment, OA. He's got paroxysmal AF. He's on rivaroxaban for his AF. He's on aspirin, metformin, atorvastatin, and ramipril. And when you go and see him, he looks fairly settled, really. So his chest pain is sort of settling, but he said he has some sort of central chest pain, didn't radiate anywhere, but he felt mildly short of breath with it. And he describes it about a 7 out of 10 chest pain. The chest pain was sort of, crushing in nature. So sort of fairly sort of concerning for some kind of cardiology type chest pain. And this is the ECG that you get. So I don't know if anyone wants to have a go, or just sort of point out some of the sort of major abnormalities in the ECG if you want to have a go. You don't have to, I can sort of just point some of them out. So let me just move this a little bit so I can see it. So you can see some sort of, so if you're going to go through it systematically, you can sort of talk about the rate and the rhythm and everything. But if you sort of just sort of pointing out major abnormalities, so I'd say there's some T-wave inversion. So T-wave inversion in V3, V4, some sort of biphasic T-waves. I don't know if you agree. So generally sort of not the most normal looking ECG. And when you compared it to his previous ECG, so his admission ECG was fairly normal. He had some Q waves, but generally sort of pretty normal up until that point. So what I did in that scenario, and see if you would have done the same thing, is I asked for a repeat ECG. So I wasn't 100%, satisfied with that ECG. So, and that's something I would also advise you to do. So if you're not 100% sure, if it's sort of got some T-wave inversion and things that maybe they don't have a previous ECG to compare to, then ask for a repeat in about half an hour. And then do a full A to E. So go and see him, check he's hemodynamically stable. Is he still bleeding? What's his blood pressure doing? Is he tachycardic? And in this case, he looked, fairly settled, really. His blood pressure was fairly normal. His heart rate was fairly normal as well. And as I say, the bleeding had settled. And then do a full set of bloods. And as an F1, I think a really sort of a top tip I learned, like coming towards the end of final year is VBGs are really good for a quick assessment of HB. They're not massively accurate, but they give you sort of a good ballpark figure. So get some bloods off. So do a quick VBG and then send off some formal bloods. So send off an FBC, a clotting, all your usual kind of stuff, group and save and a cross match, and do a troponin. And then at this point, let your seniors know. So I phoned the general surgical SHO and they were in theatre, but they were sort of, fairly happy with what was going on and sort of said to crack on, basically.
Before you go on,
Mm.
I got a question. Does anybody have any ideas what's going on with this case?
Could they be having a secondary MI because of the anemia?
Yeah, so this one is going to be a type 2 MI, as you say. So this is just a repeat ECG, so just showing that things are sort of normalizing. So yeah, so this
sorry, do you mind just going back a second?
This one.
So this is really an important point, and I'm glad you mentioned that. Repeating an ECG is really important. When you've got an abnormal ECG, always repeat it after a period, maybe 10 minutes, 15 minutes or whatever. It's important to know, is the patient in pain or not in pain? So for example, the first ECG is abnormal, they're in pain. The second ECG, they're not in pain and it's normal. That tells you that it's a dynamic, there are dynamic changes. There are dynamic changes, and it's important to distinguish an abnormal ECG with fixed changes compared to one which has got dynamic changes. Dynamic does suggest that there is something potentially acute that's going on, there's an acute process going on, whereas a fixed changes may be related to his previous MI, for example. And someone mentioned about Whelan's type pattern on the first ECG, and yes, that's a really good point. We call that Whelan's pattern, where you get T-wave inversion across the sort of V1 to V4, and usually get quite deep T-wave inversion. And you can get these biphasic T-waves as well. Sometimes it's called LAD syndrome because it's very indicative of sort of proximal LAD lesion. So that was well spotted.
Yeah. So yeah, as Graham said, so this would be a type 2 MI, which is something that I hadn't really come across before the end of 5th year, sort of starting F1. And that's why I thought I'd bring it up today, just in case people hadn't heard of it or sort of weren't overly familiar with it, because it's something that I've seen quite a few times during on-calls. So you can see that his HB's dropped slightly, his troponin is raised. And the query is, as you know, how are you going to treat it? Are you going to treat it as an ACS? Do anyone sort of want to comment on how they would treat this? Would you sort of give them antiplatelets?
I guess you want to treat the anemia.
Yeah, exactly.
The cause.
Yeah, so this patient is coming with bleeding, and giving them antiplatelets is just, you know, going to probably make them bleed more. So at this point, what you want to do is, as you say, is correct the cause. So type 2 MIs basically are caused by a mismatch between oxygen supply and demand. So it's a different sort of mechanism to sort of a type 1 MI, which is sort of the classical MI. They can have coronary artery disease, or they might not do. And the typical causes are things like sort of tachyarrhythmias, anemia, like in this case. And I've seen that quite a few times, especially on surgery. Sepsis as well can cause it. Patients who are particularly hypoxic as well. So anything where there's going to be a mismatch between your oxygen supply and demand to your myocardium, basically, is going to cause that sort of pattern. And as you say, you need to treat the cause. And here's sort of a bit of a schematic in terms of just sort of helping to sort of visualize what's going on. So this is your sort of typical MI, so type 1, so MI with acute coronary artery obstruction. And this is just sort of talking about type 2 MIs. So you can either have sort of normal coronaries, or you can have an element of coronary artery disease as well. And, you know, as you said, so treat the cause. So if they're septic, treat the sepsis, stop the bleeding, rate control the patient. So in this scenario, so if you've got a patient that's bleeding and they've got an MI secondary to that, then you need to sort of correct the anemia. So transfuse the patient. So you've already sent off bloods for sort of cross match and everything, but get them a bag of blood, you know, sooner rather than later. And then get some help as well. So speak to the medical registrar or the cardiology registrar. In this situation, I actually spoke to both of them, and they both pretty much, you know, said the same thing. So you're not going to sort of give antiplatelets in this case, but you need to, you know, do the supportive thing. So, you know, normalize their HB, try and stop them from bleeding. So their rivaroxaban's already been held. Don't give them any more antiplatelets. Get a repeat troponin. And at this stage, you're not going to do anything like you know, take them for an angiogram. But that would be sort of up to the cardiology team about what they want to do in the future. Does that all make sense, everybody? Or any questions at all?
I think there might have been a question. Let me just have a look.
Mhm.
No, there wasn't a question, but I just wanted to mention about the rivaroxaban and aspirin thing. So this comes up quite a lot. And actually, when you're an FY1, often you'll be the person clerking in patients. So, and you'll be taking the drug history, and you'll go through the medical history and the drug history. If you notice that a patient is on rivaroxaban and another antiplatelet, or even more, more antiplatelets, you should always question it. Yeah, I'm not saying you shouldn't prescribe it, but you should question it. Why are they on both? Because being on both of these agents really significantly increases the risks of bleeding, in particular GI bleeding. And actually, usually rivaroxaban and aspirin usually get upper GI bleeding, but anyway, it's in this case it was lower GI bleeding. So really question that and find out the reason why. If they've had an ACS within a year, or they've had PCI within a year, then that would be a reason to be on both those medications. But usually we don't extend it more than a year because there's a high risk of bleeding. Then the other thing, when you're treating anemia, if it's iron deficiency or related to blood loss, yes, you may need to transfuse the patient, but also you got to think, where is it coming from? Where's the bleeding coming from? Because these agents, they may not sort of precipitate, they may not be the cause of the GI bleed. They just exacerbate it. So usually there's some abnormality, whether it's a GI bleed or whether it's a bladder, a urinary, hematuria, or whether it's epistaxis. Those are the common ones. You want to basically find out what the cause of the bleeding is, sort of where is, what the lesion is, and try and get that treated. And that it might be polyps or it might be malignancy, for example. So they're going to need to have, colonoscopy, OGD, etc., to look into that.
Yeah, exactly. So yeah, as you say, so in this patient, it was sort of flagged up that they were on aspirin and rivaroxaban. So the rivaroxaban was held and the aspirin was eventually stopped, basically. And as you say, so they then had a colonoscopy to sort of look for any site of bleeding, and had then sort of a CT scan for any site of bleeding as well. So yeah, then you sort of come back to where's the bleeding coming from and why are they sort of so anemic, basically. So final case, and this was one that happened to me about 2 weeks ago when I was on nights. And I was the F1 on ward cover overnight, and I got bleeped to one of the Jerry's wards for a patient who's scoring a 7. So again, just sort of what do you want to know from the nurses at this stage? Anyone want to shout anything out?
I guess you want to know well, the primary reason for the bleep, if they're scoring, where they are, and well, anything to identify the patient.
Yeah. So what, why are they scoring? So what are they scoring for? Who's the patient? What are they in for? All those sorts of things, and then just sort of baseline things again. So ECGs. Can you repeat the obs? You might ask them to sort of if they can start doing bloods for you. That might be quite useful as well if they can.
This is a really, I find this really annoying, when you get these type of bleeps, because what does even that mean? A scoring 7? Because does anyone have any idea what scoring means? Scoring a 7? Well,
so based on the early warning system.
Yeah, exactly. So you'll literally get weeks and people saying, someone's scoring a 7, can you come and see them? And you've got no idea of, that can be so variable in what that means as well. But yeah, so every hospital has sort of the Muse system. So your sort of early warning score, as you say, and you sort of score for certain parameters that are off normal. So in terms of things off of, from your heart rate, your respiratory rate, your oxygen saturations, temperature, respiratory rate, all those sorts of things. And the more abnormal your observations are, the higher your number. So a higher number is more concerning. So patient scoring a 7 is fairly significant, really, and you'd be fairly worried about them at that point. But sometimes you get no more information than that. So sometimes it'll come up in your iBleep, which you've already spoken about, just saying patient scoring a 7, please review, and no more about them. You don't know who the patient is, why, what's sort of contributing to that number, what they're in for, what we're treating them for. So phone them back and get some more information. So as we've already spoken about, so why are they scoring? So what are their observations? What have they come in with and what are we treating them for? What's their background? And as I say, if they can do take some bloods for you and run things like a venous blood gas. That'd be amazing. And doing an ECG as well. And just a bit of practical sort of help as well. Depending on where you work, certain people are sometimes told about people who are unwell overnight. So sometimes at Wythenshawe, the night practitioners who are sort of well-trained nurses are told about patients who are unwell overnight, and will sometimes be already there when you get to see a patient, and they'll be sort of starting to help manage them as well. And in the daytime as well, sometimes critical care are told about people. So that's just a fairly reassuring thing as well, that depending on where you work, you sometimes get more help as well. And this is what you find out from the nurses. So it's an 82-year-old lady, and she's on the short stay Jerry's ward. And she came in a couple of days ago, just some general abdominal pain, likely secondary to constipation. And really her admission is for sort of social reasons. So she can't go home. She wouldn't cope at home on her own at the moment. So she's here until we can sort out some package of care for her. So some carers to go home with her, basically. So, nothing really concerning in her admission history. And her observations. So she's tachycardic. Her respiratory rate is up. Her oxygen saturations are low. So this, in case people haven't come across this before, this is, so you can obviously have oxygen via different litres, so 1 litre up to 15 litres, or you can have targeted oxygen therapy, and that's through a Venturi mask. And that sort of, basically they come in different types of Venturi masks. So they go 24%, 28%, and they keep going up to about 60%. So, the higher the number, the percentage, the more oxygen you're needing. So to have sats of 87% and you're on, a fairly sort of good going oxygen amount is quite concerning already. She's not got a temperature, and her blood pressure is quite high as well. So that's what I got told on the phone. So I went to go and see her. And this is what I saw. So on arrival, immediately, she looked very acutely short of breath. So the bed was lay flat, but she was sort of holding the bed rails, sat up, gasping for air, trying to catch her breath. And you could sort of hear her noise breathing just from sort of walking into the bay. So immediately quite concerned about her. So in this case, do an A to E. So, that you're not going to sort of find out any more information until you properly examine the patient. So I wasn't too concerned about A, so she was maintaining her airway, she was able to talk in short sentences. But moving on to B, so she was very tachypneic, so her respiratory rate was about 35. She had really sort of loud respiratory sounds on auscultation, so some pretty loud creps. She had wheeze as well when you auscultated, and her SATs were low. So at that point, you sort of should treat as you find. So SATs of 88%, at this point, don't be sort of messing around with any of the oxygen. I just put her on to 15 litres and just bring up her oxygen levels. And then after that, you can then sort of move on. The other thing to do in this sort of situation is sit the patient up. That will always help, really. So sit the patient up, put them on oxygen, and they'll probably feel already a little bit better. Moving on to C, so she was hypertensive, she was tachycardic, so she was sort of running around about 135 beats per minute. This is her capillary refill time, so a bit prolonged, so capillary refill time of about 4 seconds. She had some pitting edema up into her mid-thighs. Her calves, she didn't have any evidence of a DVT, but her JVP was raised. Her heart sounds were normal, but she had been, if you sort of reviewed her fluid balance chart, which I'd definitely advise you do, she was in a positive fluid balance, which basically means that she's been given more fluid than she's sort of gotten rid of. So she's in a, she's got more fluid on board than that she's passed. Then sort of the rest of the examination generally is normal. So her BMs are okay, her pupils are fine, pupils are equal and reactive to light. Her GCS is 15 out of 50, and her abdomen is soft. So as I say, so some immediate management plan that we already talked about. So sit them up and titrate your SATs to more than 94%. So just doing those two things, so sitting her up and putting her on 15 litres, she already looked a lot better. So that being the first thing. And then once you've done that and the patient's looking a little bit better, you can then go and have a quick read about what's been going on and have a think about what might be causing this. So I'd say, so she's 82 years old, admitted with abdo pain, and no sort of concerns on admission. but she's been seen for the past couple of days. So she was seen the night before previously because she was in fast AF, and that's new. So she's never been known to have AF before. And she's got a heart rate of about 110 to 130 for the past 3 days. And that's just been treated with IV fluids, and it hasn't really seemed to bring down her rate. So she's still been sort of going on at about 110 for the past sort of 3 days. And it's not really clear why that's been happening, really. In her past medical history, as you can see, some sort of fairly standard things. So she's got raised blood pressure, she's got type 2 diabetes, and her meds, again, are fairly sort of straightforward sort of things. If you just note though as well, she's on frusemide 20 milligrams normally. And these are her bloods today. So again, fairly unremarkable. So her CRP is sort of, you know, a little bit raised. So normally sort of less than 5 generally. White cells are fairly normal. This is sort of her baseline renal function. If you just notice that her potassium's a little bit low, so normal is 3.5 to 5.5, so her potassium is a bit low, and her magnesium is a little bit low as well. So that's another thing to just sort of have in the back of your mind as well when you're thinking about how we're going to manage this. So does anyone want to shout out what they might be thinking at this point? So what the way that she's looking and the way that sort of the way that you examine her, what you'd be thinking at this point?
Did you say that they were treating the fast AF just with IV fluids?
Yeah, so just been sort of treating IV with IV fluids. That she's been stable up until that point. So just been sort of rehydrating her, presumed all secondary to sort of dehydration. Does that sort of make you think about anything in particular?
Like fluid overload, or pressure on the heart. If they're in AF, it could decompensate into
exactly
heart failure.
That's certainly what I was thinking. And I've seen a few people who've sort of gone into sort of you know, had fluid overload, and they sort of tend to present in a fairly similar way, and it's in that sort of way that she presented. So as you say, it's the combination, really, the fact that she's been in fast AF for about 3 days, and something that I didn't really realise, I don't think, properly before starting, was that leaving a patient sitting in a tachyarrhythmia for a long period of time, you know, they're going to at some point probably decompensate unless you switch them out of that rhythm. So leaving people sitting, especially in fast AF, where you're sort of not getting adequate sort of or sort of you know, good blood flow, you're going to increase the pressure back onto your lungs, meaning that you're sort of increasing your, you know, your pulmonary sort of congestion and everything like that. So you're going to be at high risk of decompensating into pulmonary edema, and also giving fluids as well. So we've been giving fluids on top of her sitting in fast AF as well, and the two combined just mean that she's at some point going to sort of decompensate or sort of tip herself into fluid overload. So that's certainly what I was thinking as well.
I just want to mention something very quickly, Steph. Does anybody have any ideas why her potassium and magnesium might be low?
Is that to do with like a dilutional effect?
So what you're referring to, sometimes you can take the bloods from a drip arm. Is that what you're referring to?
Yeah, sorry.
Yeah. So that's important to know. So, you know, you may want to repeat it. What's the trend of the blood? But if it says genuine in this scenario,
if the magnesium is low, can that cause the potassium to be low?
Not necessarily, but so what I was trying to get at is, so frusemide, so diuretics can drop the potassium and the magnesium, and also PPIs are very common as well. She's not on one, but they're another common cause. And then obviously if you're vomiting or got diarrhea, she doesn't have any of those things at the moment. But,
yeah, exactly. So at this stage, the things you want to do, so get an ECG, you know, send off all your blood tests. So again, so do a venous blood gas, and that'll give you a really good indication of how much oxygen, you know, what her oxygen levels are like in her blood. You can send off a troponin, and I don't know if anyone wants to sort of any ideas of why you might send off a troponin at this stage, and you know, whether you would do or whether you wouldn't. But certainly my thought at the time was, she's, you know, in my sort of thought process was, she's got sudden onset shortness of breath and sudden onset fluid overload. has she had a cardiac event that's caused it? So that can sort of go through in the back of your mind as well. Then you want to sort of get some electrolytes. So repeat the magnesium, repeat the potassium, the sodium, the calcium, the phosphate, and then get them a chest x-ray. So at this point, you're not going to want to send this patient to the x-ray department. They're on 15 litres. So ring for a portable chest x-ray and get them to come and do that on the ward. And that'll give you, again, a really sort of quick sort of look at what's going on, basically. So this is the ECG. I don't know if anyone wants to have a sort of a very, again, sort of quick summary of what you think is going on with the ECG.
I can go just the main findings. It looks irregular. Is it fast? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13. 21 times 6 is what it's tachycardic, so it's fast, yeah. There's no P waves as well, I should say. There are, you can see a bit of variation in V1, but that's pretty indicative of AF. There, I don't think there's any ST elevation or any other signs of ischemia.
Yeah.
There's no ST depression. There's no T wave inversion. V2, the T wave looks potentially hyperacute, but it's not the same as the one we saw earlier.
Yeah, good. Yeah. So as you say, so the main findings, so the tachycardic, I think I worked this out, is about 130 or something beats per minute, I think. And it's irregular. You can't see convincing P waves. So this is fast AF, as you say. And just for the interest of time, I'm just going to quickly sort of run through the other stuff. This is actually this wasn't her chest x-ray, but this was fairly similar, actually. I was expecting her to have fairly good going pulmonary edema on her chest x-ray. And she didn't. She had some sort of evidence of sort of upper lobe changes that you can get. So the sort of increased vascular and sort of increased markings up here at the top. And it's sort of a little bit hazy. But I wasn't sort of overly convinced, but I think basically we sort of caught this in just as she's about to go into sort of pulmonary edema, basically. And this is, this is sort of what I thought was going on. And this is sort of why I called the medical registrar to come down and have a look at this patient. And what we came up with the idea is that she had cardiogenic pulmonary edema. So as I say, it can be sort of caused by lots of different things. So it could be a cardiac event. So that's why I sort of mentioned checking troponin in these patients. If it's sort of sudden onset, they had some chest pain before. Patients sort of immediately after having an MI can also sort of go into pulmonary edema. Valvular heart disease. This is probably actually one of the main ones that you see in hospital. It's iatrogenic, especially you see this on sort of surgical wards, patients who are given sort of quite intensive and aggressive IV fluid resuscitation. They then sort of at some point they have just too much fluid and then they sort of go into sort of pulmonary edema. PE as well can cause pulmonary edema. And this is the one that we're talking about here. So she was in tachyarrhythmias. So this is sort of what can happen. So tachyarrhythmias lead to pulmonary edema. You're sort of not getting the proper atrial systole, therefore you're increasing your pulmonary venous pressure and you get a buildup of fluid in the lungs that makes people obviously then acutely short of breath. So
very, very quickly, Steph, is that so yeah, PE can cause both. So PE can cause AF and trigger AF, and that can be a reason for hypoxia as well. If you see a chest X-ray which is out of keeping with the degree of hypoxia or oxygen requirements, you always have to think of PE in the back of your mind. That's always possible. And the other reason why sometimes you get those chest X-ray changes is because you've already given the treatment, and by the time they come for the chest X-ray, they've actually pretty much a lot of the fluid has come off the lungs. So that sometimes can happen if there's delay between the treatment with furosemide and the chest X-ray.
Yeah, exactly. So yeah, basically don't be sort of too put off if the chest X-ray looks not too abnormal, really, because at first I was like, oh, have I completely sort of gone off on the wrong tangent here? But I think, yeah, as you say, I think we've probably just about managed her. So get some senior help. So call the medical registrar and start offloading some fluids. So you can just give sort of 40 milligrams of IV furosemide stat and see how they go. And then you want to, sort out the problem of why they've gone into fluid overload. So, get on top of the tachyarrhythmia. So rate control them properly. So things you can do, so you can either use things like bisoprolol or digoxin. In this case, we used bisoprolol, and that's for a couple of reasons. Her blood pressure at some points was sort of bordering sometimes on quite high and then sometimes dropping a little bit lower. But also the main reason that we didn't give digoxin was that her potassium was low. And that's something that I didn't, again, know too much about before starting F1. You shouldn't give digoxin if your potassium is low. So we went for bisoprolol in this instance. So give 2.5 milligrams and see what it does to the rate. And then also correct the electrolyte disturbances. So AF can be caused by electrolyte disturbances. So correct the magnesium. And IV magnesium is also very good for AF in general, actually good for fast AF. So we gave some IV magnesium. And then you can think about other things if things are still, you're not in control of things. So if the patient's sort of in flash-borne edema, then sometimes QTN infusions help, so giving nitrates. Inotropes and CPAP, you're obviously not going to be starting doing that on the ward. You want to talk to sort of ICU about those sorts of things, but there are other options of where you can go. And then in terms of ongoing management, so once that patient is sort of adequately rate controlled, and if they haven't sort of gone back into sinus rhythm, think about, do you need to anticoagulate the patient? So work out their CHA2DS2-VASc score and think about, do they need to go on a DOAC or something like that? But sort of generally, sort of your initial management is things that we talked about. So, sit them up, give them oxygen, offload them, and then sort out the reason of why they've gone into that tachyarrhythmia. So rate control them. And after just giving her some oxygen, sitting her up, giving her 40 of Freezy and giving her 2.5 of bisoprolol, after about an hour and a half, she was pretty much, her rate had come down to about 100, 105, 110. Her oxygen levels had, her oxygen requirements had come right down, and she was looking a lot better. So it's a fairly sort of quick turnaround and a quick sort of solution, really. So that's sort of the end of the cases and the scenarios. I'm hoping I haven't confused you. I'm hoping that this has sort of reassured you in some ways that actually, if you're not sure of what to do, you feel like you don't really know what you're doing, get some help, and people will come and help you. And these are sort of the scenarios that you would be expected to ask for help for. You wouldn't be expected to manage any of these on your own. So never be afraid to ask for help, basically. And if you're stuck, if you're not really sure what's going on and you think you've got time, start with the basics. So just go and do a quick A to E. And if at any point you feel out of your depth, get some help. And that's everything from me, really. Yeah.
Thank you very much, Steph. That was really good. Just a note for everyone, the feedback form is in the chat. If you're able to fill that out, that would be fantastic.